still Dr. Florence for this kind of invitation, which gives me the opportunity to share with you today some of the recent work I myself, with my group, have done in Milan, basically. I will talk as a beginning about orthostatic intolerance in hyperadrenergic postural orthostatic tachycardia, and I will address the effects of the transcutaneous vagus nerve stimulation. That will be the first topic. Going on, we will see what's going to happen. This slide summarizes the hemodynamics of a typical POTS patient. I am very linked with this slide because that was the first case of POTS I met. This slide was done in 1995 when I had the opportunity to get in touch for the first time with a patient suffering from postural orthostatic tachycardia syndrome. And as everyone may be aware, this syndrome is characterized by a typical hemodynamic profile upon standing, characterized by an excessive tachycardia without significant changes in blood pressure. Here you have the heart rate, here is the blood pressure. Incidentally, at those times, we were recording blood pressure invasively, which means that we put a catheter into the radial artery of the patients. Okay, interestingly enough, when the patient is lying down, there are really very few symptoms. Maybe anxiety is the most common. But when the patient is reaching the upright position, a number of symptoms appear, and they may impact badly the quality of life of the POTS patients. And they are palpitation, shortness of breath, lightheadedness, dizziness, fatigue, reduced exercise tolerance, pre-syncope, and even syncope. We have to keep in mind that this syndrome is characterized not only by orthostatic symptoms, but also by what we call non-orthostatic symptoms, accounting for GI tract involvement, such as bloating, nausea, vomiting, constipation, diarrhea, abdominal pain, bladder dysfunction, or generalized associated symptoms such as fatigue and sleep disturbances, which are the most common. We have to keep in mind that many of those of the symptoms I just named are shared by other disorders, such as the chronic fatigue syndrome or the joint hypermobility syndrome or the Ehlers-Danlos syndrome, the fibromyalgia also, up to a recently developed disorder, which is the long COVID POTS-like. Okay, even the long COVID may show up with the symptoms similar to the one we can easily find in POTS. What is the transcutaneous vagus nerve stimulation? It's a relatively novel methodology which enables the researchers and the clinician to induce a neural stimulation in order to increase the vagus nerve. Let me, do this one, the vagus nerve efferent activity. TVNS acute effects on POTS are characterized by an increase in the parameters reflecting the cardiac vagal modulation and in a decrease in mean heart rate. The two things are quite related, as you may imagine, and those were the first studies done by Diedrich, which were followed by our contribution in 2019, first named is Dana Schiffer. Okay, here is the instrumentation we are using, and on the right side, the supposed anatomical pathway involved in this methodology. So this is the device is a battery-powered device which gives an electrical stimulation that is carried by this probe to the Simba concha, in our case of the right outer ears, resulting in an activation of the vagal afferents. Those neural afferents are supposed to project to the nucleus tractus solitarius up here, which in turn is linked with the number of neural structures. For example, the rostroventrolateral medulla, the activation of which may result in an increase of the vagal activity to the sinoatrial node, a reduction of the sympathetic drive to the sinoatrial node, and the reduction of the sympathetic vasomotor control. So we have, based on recent data, we may say that the stimulation of the afferents vagal fibers may result in clear effects on the heart rate and on the sympathovagal balance of the heart, but also this kind of stimulation may inhibit the sympathetic drive to the vessels. And this is quite interesting. I'm gonna show you in a while what is happening. However, and this is very important, we have to keep in mind that there are also direct effects on the symptoms, which may go through ascending neural pathway that account for the effectiveness of such a methodology in controlling symptoms such as depression or generalized pain. We have to keep in mind, we have not to forget that this methodology was marketed in Europe, for example, for controlling depression and for controlling generalized pain. Okay, there are also anti-inflammatory effects that I will not address today. Dealing with this methodology, and a very important part is related to the technical aspects of the neural stimulation. For example, the frequency by which we are stimulating the vagal afferents seems to play a major role. Thanks to the preliminary work done by André Diedrich from Vanderbilt University, who is joining us in the data I'm going to present to you in a while. Thanks to his work, he could identify the optimal frequency that of this stimulation, which is in between 25 and 50 hertz. And because that frequency was able to increase the power of the high frequency component RRR variability, which is a recognized marker of the vagal efferent activity to the heart. So if we use those kind of frequency, we have the best the optimal effects on the power of this component, and we have the maximum effects on the RR interval, which means basically on heart rate. Okay. And you may see this concept up here, where the stimulation at 50 Hertz is able to increase the timing of tilt, as well as is characterized by the greater effects on heart rate. So the greater reduction of heart rate was obtained by using 50 Hertz of stimulation. Okay. In a subset of POTS patients, there is evidence of centrally derived sympathetic overactivity and of a remarkably reduced cardiac vagal modulation when they are supine. And these patients are classified as having an hyperadrenergic phenotype. So they are hyperadrenergic. The data I'm going to present to you were organized as it follows. We originally focused on a large cohort of outpatients, on a large cohort of outpatients suffering from chronic orthostatic intolerance. Okay, so they were coming to our outpatient clinic and then claimed of their incapability to stand up properly because of malaise, disease, lightheadedness, what we call pre-syncope sign and symptoms. Among those, we pick up the subgroup fulfilling the POTS diagnostic criteria, and we differentiate within that POTS group those characterized by an hyperadrenergic profile that I will give you in a while the features and the for this kind of population. Within this group of hyper-POTS patients, we evaluated the autonomic profile and the potential symptoms intensity modifications after 40-day lasting TVNS, transcutaneous vagus nerve stimulation. And we also looked at if there were any post-TVNS effects of such a stimulation. So we followed up those patients after the stimulation of the vagal afferents was interrupted. This is an interventional proof of concept clinical trial with the two major aims. The first one was to assess the effectiveness of a 40-day lasting, which we call chronic, transcutaneous vagus nerve stimulation on both the autonomic profile and symptoms intensity in hyperadrenergic POTS patients. And in doing that, we followed the hypothesis of the presence of a potential link between symptoms intensity and an abnormal cardiovascular autonomic profile. The second aim was to assess the currently unknown long-term effects of transcutaneous vagus nerve stimulation on both the autonomic profile and symptoms intensity after transcutaneous vagus nerve stimulation discontinuation. And here is summarized the protocol. We studied 22 hyperadrenergic POTS patients. Here are the age, BMI, the disease duration. And we define hyperadrenergic POTS as POTS individual characterized by a supine HF component of RR variability lower than 200 square millisecond. And they had also to accomplish a second criterion, which was the upright norepinephrine levels greater than 600 picogram per milliliters. So the 22 hyperadrenergic POTS patients had to fulfill both of those preconditioning in order to be named hyperadrenergic. In every subject, we continuously recorded the ECG, the blood pressure, the respiratory activity, and the muscle sympathetic nerve activity. It is just a reminder that the muscle sympathetic nerve activity technique is the golden standard to assess the efferent sympathetic drive to the peripheral vessels. And you may see up here the bursts, which are a number of a single sympathetic fiber discharging concomitantly. Okay, and this is a period of neural silence. In every subject, we considered 15 minutes in the supine position, and every subject underwent a 75-degree head-up tilt, which was maintained for 15 minutes. The RR interval and systolic arterial pressure variability were analyzed by autoregressive spectrum and cross-spectrum analysis technique in order to get spectral markers of assessing the cardiovascular autonomic profile. Here is the study protocol. Patients were studied on 3 different occasions. On day 1, we had the baseline, the pretest. At this moment, the patient had to fulfill, they first of all underwent a general physical examination. They were enrolled and they had to fulfill the questionnaires we are going to show you in a moment, and a tilt test maneuver. Thereafter, they had to they were provided with a stimulation device, and they had to undergo a 40-day autonomous home stimulation for 4 hours every single day. So we had a chronic stimulation lasting 2 weeks. Then the patient had to come back to the laboratory, to our clinical laboratory. They had to fulfill the post-stimulation, the TVNS, just close to the end of the TVNS, and they had to undergo a second tilt maneuver. Thereafter, for a subset of those patients, we assessed the long-term after effects of the stimulation. So we assess those patients in a period of time which was greater than 30 days, and it was within 2 years. Okay. I have to tell you one thing which is important to understand how tough was to conduct this study. We started in Eastern 2019, okay, and we were quite unfortunate because we met the COVID outbreak and the lockdown, which was very tough in Italy, and quite prolonged in Italy. as you may remember. So we were obliged to stop the protocol, the study, for many months, and that create several problems because we, especially for this post TVNS washout period, which was quite long, mostly because of that. Okay. We had also exclusion criteria, such as an age lower than 18 years of age, other cause, as you may read up here, including the long COVID POTS-like syndrome, okay, which is something that we wanted to keep apart. Okay, every subject underwent a pharmacological washout in order to be analyzed, to be studied without any drug. And here are the variables that we used to carry out the autonomic assessment. We relied on the muscle sympathetic nerve activity to assess the sympathetic modulation to the vessels. And here is an example. We assess the cardiac sympathovagal instantaneous relationship or balance, somebody call it sympathovagal balance, which are the low frequency and the high frequency component of our variability. Okay, and we used the ratio between the low frequency and the high frequency oscillatory components, as well as the absolute power of the high frequency component of our variability as a marker, as a non-invasive marker of the vagal modulation to the sinoatrial node. Okay. We used also the low frequency component of systolic arterial pressure variability as a non-invasive marker of the sympathetic vasomotor control. We assess plasma norepinephrine and epinephrine by HPLC methods, and we assess also the baroreceptor sensitivity in the frequency domain by means of the alpha index. Such an index is obtained, is computed by the square root of the ratio between the absolute power of the low frequency obtained from systolic arterial pressure variability and the low frequency component of our interval variability. As to the symptoms assessment, we assess the orthostatic symptoms by using the modified Vanderbilt Orthostatic Symptom Score, MVOS, both in the supine position and and by the end of a 75-degree head-up tilt. Here are the single domain, but what is very important is the total score, which is a convenient final index accounting for all the different individual domains like mental clouding, blurred vision, shortness of breath, and so on. I do apologize for this slide, which is taken from the paper we just published in the European Journal of Internal Medicine last September. Here are the clinical feature and the demographics of our population. Okay, the large majority are female, as we know in the case of POTS. Here are the comorbidities. And please notice that the Ehlers-Danlos syndromes was the most common comorbidity, followed by the chronic fatigue syndrome and the fibromyalgia. This slide shows an example of the variables we recorded in a representative POTS patient. We have the supine position, rest and the 75-degree head-up tilt. In the pre-TVNS and just the 15 days, so 1 day after the 14 days lasting TVNS was performed, both in the lying down position as well as in the upright position. Please notice that TVNS induced a slight reduction in the heart rate, no changes in blood pressure, nor in the end tidal CO2, which means basically in the respiratory pattern as well as in the capability of exchanging oxygen by the lungs. Okay, but clearly at rest, if we focus up here, the muscle sympathetic nerve activity was reduced after 14 days of transcutaneous vagus nerve stimulation. During the upright position, there were, of course, an exceeding increase in the heart rate, which is a marker of the disorder, of the POTS disorders, no changes in blood pressure nor in the end-tidal CO2. As to the muscle sympathetic nerve activity, there was a blunted increase, which was unaffected by the TVNS, basically. Okay, and this is this slide summarizes the changes that were we could identify a decrease in the maximum heart rate during the 75-degree head-up tilt after the transcutaneous vagus nerve stimulation was performed for 14 days. Okay, the other parameters including systolic arterial pressure, diastolic pressure, respiratory rate, and end-tidal CO2, as already mentioned, did not change that much. Again, I do apologize for this slide, but please follow the red arrows. The upper part deals with the supine position, whereas the lower part deals with the 75-degree head-up tilt. Please notice that TVNS induced a remarkable decrease in the muscle sympathetic nerve activity rate. So the sympathetic drive to the vessel decreased. There was an enhancement of the high frequency component of our variability, a marker of the vagal modulation to the heart. There was a decrease in the low frequency, high frequency ratio, suggesting that the sympathovagal balance was shifted towards a vagal prevalence. So in the supine position, we may say that the autonomic profile did change a lot after TVNS, and that modification was consistent with the blunted sympathetic drive to the vessels and an increase of the vagal activity to the heart. As to the upright position, a similar pattern could be obtained in the muscle sympathetic nerve activity after TVNS. Okay, so even in the upright position, the vagal activity decreased the sympathetic drive to the vessels. There was a tendency to decrease plasma norepinephrine, as well as it was the case in the resting condition, although that change was not statistically significant. And interestingly enough, there was an increase in the alpha index up here, which is a marker of the baroreceptor sensitivity, which was increased by the TVNS procedure. And if we shift to the symptoms intensity, please notice that the MVOS total score, so an index which is a comprehensive index of the orthostatic tolerance or intolerance, to be more precise. So orthostatic intolerance was significantly reduced after TVNS, as well as in both conditions at rest and during the upright position. Okay, let's forget for a while about the post TVNS. Okay. Okay, and this table summarizes what I just showed you, so we are not going to spend any time about that. Now let's concentrate with the post-TVNS symptoms intensity, heart rate, cardiac vagal modulation, and baroreceptor sensitivity magnitude. What happened after the TVNS was stopped? Okay, so what are the is there any long time after effects of such a methodology? The answer is yes, indeed. There is some kind of effects, and indeed, we have a reduction of the orthostatic intolerance in the long term during the tilt maneuver. We had a clear increase in the HF component in the long term, both at rest and during the tilt maneuver. So there is an overall increase in the vagal activity, which is reflected in a clear reduction of the heart rate during the upright position and the tendency to reduce heart rate even in the resting position, but that was not significant. And by the end, the baroreceptor sensitivity, as assessed by the alpha index, was enhanced, increased in the long terms after TVNS was stopped. Okay, so in conclusions, ladies and gentlemen, this proof of concept study suggests that 40 days of daily transcutaneous vagus nerve stimulation may shift the autonomic profile in hyperadrenergic POTS, enhancing cardiac vagal modulatory activity, reducing sympathetic activity to the vessels and to the heart, and relieving key orthostatic symptoms. Many of those, very interestingly and to some extent unexpectedly, okay, many of those benefits persisted even after discontinuation of the TVNS, suggesting a potential sustained therapeutic effect. We are very careful in this final statement because the study was not originally planned to address this issue. But anyway, we were curious. So during the study, talking each other, we said, well, let's have a bet, okay? And by the end, it turns out that there seems to be a potential sustained therapeutical effects even after TVNS discontinuations. Of course, these findings, I do apologize for this typing error, support TVNS as a promising strategy for improving autonomic regulation and quality of life in hyperadrenergic POTS patients. And here are the references for the paper we just published and I dealt with. Now, if you give me 10 minutes, I will go very quickly on a second study that we are about to finish to write, okay? And in that study, we assessed and we compared basically orthostatic intolerance in hyperadrenergic POTS patient versus non-hyperadrenergic POTS patients. And both groups underwent a transcutaneous vagus nerve stimulation. Okay, so we look at again, both the autonomic profile and the symptoms in those two groups. Um, I have to ask you to forgive me about the quality of the slides. They are not optimal, but I just finished today to build them up. Okay, so consider them as a to some extent, a work in progress, although the study has to be considered finished. So what is the reasoning behind this study? We focus again on a large cohort, of outpatients suffering from chronic orthostatic intolerance. And from this large group, we picked up those fulfilling POTS diagnostic criteria. And within that group, we differentiate those with an hyperadrenergic phenotype, the hyperPOTS. And then we gather the remaining POTS as a non-hyperadrenergic POTS group, okay? We provide an healthy control group as a reference for comparison with POTS groups, autonomic profile, and orthostatic and autonomic symptoms. And we evaluate the autonomic profile and symptom change in both POTS groups after 14-day lasting TVNS. So we have two parts of the study. The first part is comparing the two phenotypes, hyperPOTS versus non-hyperPOTS and healthy controls. Second part is to compare the effects of TVNS, transcutaneous vagus nerve stimulation, on both groups of patients. Here are the population. We had a total of 114 individuals, 51 healthy controls, and 63 POTS patients. We had 23 hyperadrenergic POTS fulfilling the two criteria I just presented to you before. I'm not going through. We had 40 non-hyperadrenergic POTS and 51 healthy controls. In every subject, we recorded ECG, blood pressure, respiratory activity, and muscle sympathetic nerve activity continuously for 15 minutes while supine and for 15 minutes during a 75-degree head-up tilt. Again, RR and SAP variability were analyzed by autoregressive spectrum and cross-spectrum analysis technique in search for spectral index of cardiovascular autonomic profile. Here are the exclusion criteria similar to the one, and here is the autonomic assessment, exactly identical to the one I just showed you. So we are going quite quickly. Orthostatic symptoms were assessed by the modified Vanderbilt orthostatic symptom score, focusing on the total score, whereas the overall autonomic symptoms were assessed by the COMPASS 31 questionnaire. Again, we focus on the total score as a convenient, comprehensive index of the autonomic profile, of the overall autonomic profile of the patient. In this case, we have, from the protocol standpoint, we had two different conditions. The baseline or pre-TVNS and the control group, the hyperadrenergic POTS and the non-hyperadrenergic POTS, they all underwent this baseline condition, which was followed by a 40 days autonomous home stimulation for 4 hours a day that was done just by the POTS patients. Okay, either the hyperpods and the non-hyperpods. Okay. So, and the group of patients underwent a second TIL maneuver and questionnaire assessment 14 days later, TVNS. And here are the main results. If we look at the heart rate, white whisker plots are the healthy controls. In red, hyperadrenergic plots. In blue, non-hyperadrenergic plots. As to the heart rate, please notice, look at the lower part, that the hyperpods were characterized by greater heart rate compared to healthy individuals, as well as to non-hyperpods, which in turn had a higher heart rate as compared to healthy controls. And the same was for the upright position, for the TIL maneuver. Blood pressure was unremarkable, was similar in all the three groups in both conditions. As to the LF-HF ratio, which is an index of the sympathovagal modulation to the heart, please notice that the hyperadrenergic pods were characterized by greater LF-HF ratio than healthy controls, and non-hyperadrenergic pods, both at rest and during tilt. And in addition, the non-hyperadrenergic pods had a lower low frequency, high frequency ratio compared to healthy controls. So unexpectedly, those group of POTS patients had a blunted sympathovagal modulation to the heart. As to the upright position, as we said, both the hyperpods and non-hyperpods had a low frequency, high frequency ratio. The hyperpods had a low frequency, high frequency ratio greater than the healthy controls and greater than the one observed in non-hyperpods. Okay. As to the HF component in the resting condition and in the upright position, the hyperpods had a lower heart rate, high frequency component at rest and during TIT as compared to the other two groups. And the alpha index was this one. So basically, there was lower in the hyperpods compared to healthy control and non-hyperpods. Okay, in summary, okay, please, data are quite complex to be kept in mind. Let's focus on the non-hyperadrenergic POTS group, which was pretty much the same in the supine position as compared to healthy control. They had just greater heart rate and a greater muscle sympathetic nerve activity, but many of the other autonomic parameters were pretty much the same of healthy controls. In contrast, hyperadrenergic POTS in the supine position were greater than non-hyperadrenergic POTS as far as the heart rate, the low frequency, high frequency ratio, and the plasma norepinephrine. Okay, suggesting a greater overall sympathetic drive to the cardiovascular system. As to the 75-degree head-up tilt, again, let's start from the non-hyperadrenergic POTS and compare them to healthy controls. You see, the non-hyperadrenergic POTS group was pretty much the same as compared to the healthy controls. As to the symptoms intensity, again, the two groups of POTS patients had greater intensity, symptoms intensity, if we consider the orthostatic intolerance symptoms greater as compared to the healthy controls, both in the supine position and during the TIL maneuver. So they definitely suffered from orthostatic intolerance, the two groups. If we look at the Compass 31, what is interesting is that also taking into account the overall autonomic profile, which can be assessed by the total score of the Compass 31 questionnaire, the hyperpods and then non-hyperpods were characterized by a greater symptoms intensity, overall symptoms intensity as compared to healthy control, and the intensity was quite similar. So in conclusion, if we consider the pre-TVNS at baseline, the hyperpods patients were characterized not only by a higher sympathetic modulation to the cardiovascular system than that observed in controls, but they also seem to be more hyperadrenergic than non-hyperadrenergic pods. This seems to be an oxymoron, but at baseline, non-hyper pods autonomic profile was different from that of controls, greater heart rate both while supine and during tilt, and greater muscle sympathetic nerve activity at rest, but they were indistinguishable from controls in many other autonomic indices. So it turns out that these non-hyperadrenergic pods are in between the hyperadrenergic pods and the healthy control. At baseline, orthostatic intolerance and autonomic symptoms intensity were greater in both POTS groups compared to controls, but their magnitude was larger in hyperadrenergic POTS than in non-hyperadrenergic POTS. Okay, if we look at the effects of the transcutaneous vagus nerve stimulation, we can come up here. In red, we have the hyperadrenergic POTS. In the left part, we have the Compass 31 total score. In blue, the non-hyperadrenergic POTS. Please notice that after TVNS, both groups showed an effect, a reduction of the Compass 31 total symptoms total score. So there was a reduction in both groups. If we go to the MVOS, which assess the orthostatic intolerance, such a decrease in, which means increase in the orthostatic tolerance, okay, decrease in the intolerance, increase in the tolerance, could be observed only in hyperadrenergic pods, whereas the non-hyperadrenergic pods didn't show any significant change. There was only a slight amelioration in the orthostatic tolerance. So overall, transcutaneous vagus nerve stimulation proved to be effective in reducing the cardiovascular sympathetic activity in both POTS groups, being the extent of such a decrease likely greater in hyperadrenergic POTS than in non-hyperadrenergic POTS. 14-day lasting transcutaneous vagus nerve stimulation reduced overall autonomic symptoms intensity in both groups, but seemed to be ineffective in non-hyperadrenergic POTS as far as the orthostatic symptoms intensity was concerned. Maybe this latter aspect might remarkably affect rehabilitation strategies in the two POTS groups, may differentiate the rehabilitation strategies. Okay, and this is everything. Thank you for your attention. If you give me a couple of
we'll give you all the time.
Just one additional slide. If we specifically look at the Compass 31 gastrointestinal symptoms pre and post, look at this a dramatic reduction in the symptom score, which is also expressed by those whisker plots up here. And this represents the next study we have in mind, and we are going to start quite soon, looking at the GI tract symptoms. They are neglected symptoms so far. There are very few drugs. We do believe that this is a topic that makes the POTS patient life quite hard and quite miserable to some extent. Okay, so we do believe that this is a precise is something that we have to deal with in order to be helpful to these patients. Okay, thank you. I'm done. I've finished. Thank
Thank
you
you
very
so
much.
much. So we have a ton of really great questions. Thank you so much for the webinar and for doing this research. I love how engaged our patient community is, and they have like highly detailed scientific questions for you.
Okay.
You want to maybe stop sharing the slides, or if you hit stop share.
Okay, sorry.
That's okay.
Okay, I do this and I do,
Just like close the slide window, or you
okay,
could leave it up. It's fine. So we got a ton of questions. All right. I know you had it on a slide at the beginning, but a lot of people were asking, how did you define hyperadrenergic POTS for this study? And I think it's important to I'm going to give a caveat before you explain how you defined it in the study. I think there are different doctors who have different clinical definitions of how they decide someone's hyperadrenergic or not. I also think we don't really have a lot of great research showing us what happens in POTS over time. And I can tell you, as a patient who's had this for 15 years and probably has seen more autonomic specialists than the average patient because of my role, um, I've been diagnosed with neuropathic POTS, hypovolemic POTS, hyperadrenergic POTS, autoimmune POTS, deconditioning POTS. So I think it can change over time. And I also think clinically, it's very variable amongst doctors. But with that being said, how did you define it in this study?
yeah. So based on previous studies, we used those two criteria. So we focus on the recumbent position, on the supine position, and we considered as hyperadrenergic those patients who had the high frequency component of RR variability, which was in absolute power lower than 200 squared millisecond. I realize that this is not a clinical useful definition because it is an a posteriori definition. You need to get your patient that is suffering from orthostatic intolerance, record the ECG, do power spectrum analysis, and based on the power spectrum analysis, you got that index. In addition we had also to consider the upright position. We reasoned that the large majority, the vast majority of symptoms in POTS happens in the upright position. So we cannot neglect that the upright position. And in search for a marker, we had good evidence that a huge release of plasma norepinephrine into the bloodstream might be considered at least a proxy of the overall sympathetic drive to the body in the upright position. I said a proxy because everyone has to be aware that the plasma norepinephrine levels are the results of a clearance of the norepinephrine, which is exerted by many organs, including, for example, the liver or the lung, and the release into the bloodstream by the sympathetic neural endings. Okay, so it's a dynamic condition, and sometimes an abnormality in the clearance may account for the elevated norepinephrine levels, which does not mean that there is a primary sympathetic drive
Yeah.
to the vessel. But I'm going to finish. But having recorded the muscle sympathetic nerve activity, we have got a concomitant good index of the central sympathetic drive to the vessel, which was definitely enhanced in in POTS patients. And that finding replicated a finding of mine I did in 1998, a study with the Vanderbilt group. It was probably one of the first pathophysiological study assessing the autonomic profile, and also in those patients that were American ladies. Okay, they behaved the same of the Italian ladies affected by POTS.
And the men, we want to, there are men who get this too. So I think we have a ton of questions on, a lot of this is very detailed physiology research that is not something people get as part of routine clinical care, right? It's hard enough to find a doctor who even knows what POTS is. And so this type of research is always way more technical and complicated because when the researchers are doing it, they're like, we could have funded a study just, hey, does vagus nerve stimulation work for everyone with POTS, right? But the researchers, Dr. Furlan and others, really want to understand if it does help, what's it helping biologically, because that kind of gives more evidence for this is real and this is the mechanism that it's working by. And then that kind of leads to future research, trying to get what is the exact best stimulation approach for that mechanism. Like it's a stepwise research process. So it's very
Yeah.
technical. In a clinical setting, um, I think there's debate amongst the autonomic experts on whether or not patients really need to be characterized as hyperagic or not with specific testing. But typically, an average POTS lab that's not doing a research study on you, right? They might measure your your blood norepinephrine levels when you're laying down and when you're standing up. That's one way it's defined. Other doctors just hand out the hyperadrenergic label all the time because they think the patient seems hyperadrenergic, because they get really excessive tachycardia and maybe some hypertension on tilt. But importantly for patients to know, there's actually a condition called hyperadrenergic orthostatic hypotension. So just because you have elevation of blood pressure when you stand up, it does not mean you have this central sympathetic drive. You might, but you might not. So when patients ask us all the time, should I get subtyping testing? It's a luxury if you have a doctor who knows how to do that, but it's not really essential to have that testing to get good clinical care for POTS. As the study showed, the vagus nerve stimulation worked on both groups of patients, right?
Yeah. Yeah.
So certainly if you have a doctor who knows how to do that kind of testing, that's great, but it doesn't really change your treatment approach. And a good clinician can look at your symptom profile and say, I think this patient's going to respond well to a drug that lowers the sympathetic tone. I think this patient's going to respond well to a vasoconstrictor. And so it's more important to have a doctor who knows how to treat it clinically than knows how to do the super complicated testing, which I think very honestly that this testing results you get probably changes over time in the patients. I've had it for 15 years. When you're newly diagnosed, sometimes you have a certain profile, and then 5 years later, you have a different profile. So I think sometimes as patients, we're so desperate for answers, right? And we feel like, I mean, I certainly felt this way, and I probably still do. Like, I want all the testing to know exactly what's going on in my body, you know? But it's very hard to find doctors who do that. The good news is that this study had positive results in all types of POTS patients. We did
Yeah.
have some people asking, why wasn't it studied in long COVID? So I pointed out in the comments, I answered a few of the questions that people had typed in. This study actually started, we funded this in 2018 or 2019. So this actually started before COVID. And it's very hard to sort of change your protocol once things are going. Plus, there's also completely different research happening on long COVID vagus nerve stimulation, which is happening at Vanderbilt and probably elsewhere. That's I do think I think POTS is POTS regardless of what triggers it, but there are different profiles. If you have POTS since you're 12 years old and you're getting studied at 35 versus you got POTS 6 months ago, you probably have a different profile. And I think when you're doing when you have a new condition, long COVID or post-COVID POTS, I think that there's doctors who are doing enough research on that that are also trying to figure that out. So I don't think there was any sort of, if people were worried, like, is there a bias against long COVID? Certainly not. This is just a study that was going on before that. Other questions? I guess I'll ask you some of the questions if you'll bear with us for a few minutes more.
Yes?
I know it's kind of late in Italy.
No, 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 that's okay. Don't worry.
So, some people had asked, is it safe to use this during pregnancy? And I think I know what your answer is going to be, but I'll let you answer it. We don't know, right?
You mean pregnancy?
Right. Can you
Yeah.
use vagus nerve stimulation during pregnancy?
Uh, well, I don't think. Well, I've no data. Okay, and not having data, we say there is no evidence. But my hair is white, and I've been studying POTS since 1995. Okay, so almost 30 years. So I've got quite an experience. And well, to tell the truth, the more I get older, the more I trust on my experience as a doctor. Okay. And uh, so I would say that there are very few problems in using, I wouldn't say there are major problems in using TVNS even in pregnancy. Uh, I really don't think there are major problems. Um, it is true that we affect the autonomic nervous system, definitely. And it is true also the data in non-hyperadrenergic POTS patients seems to support this concept. There are different pathways by which the vagal afferent stimulation reach cortical areas, interfering with the pain integration. We have not to forget that this technology was first used to control generalized pain syndromes. Okay, and it works also in some kind of depression. So there are still areas which are unknown as far as the mechanism, the exit mechanism, the TVNS is working. But nonetheless, I don't see any potential threatening for ladies who are carrying on a baby in their abdomen, I mean, their uterus.
Yeah. I just pulled, as you were answering that, I looked on PubMed and found a review paper on pregnancy and vagus nerve stimulation, and it seems to say the same thing. I
Okay.
put a link to it in the chat, and if anyone, it's not the same tool as the Q&A tool. It's a different button on the bottom of your Zoom tab. And so I put a link to that to anyone who might want to read it. Certainly, I think we have been telling everyone who's asking us about this, please talk to your doctor before you do it.
Oh,
Um, now, a lot of doctors are not going to know what this is. They're not going to feel comfortable with it yet, but it is a medical treatment. So related to that, are you aware of any adverse events in your patients or in other vagus nerve stimulation research that are things to look out for?
of course, we carefully checked side effects of the methodology, especially at the beginning. Oh, first of all, don't forget that every researcher of my group, I myself was leading, we underwent the stimulation. We had to feel, what we were going to propose the patient. Okay, so this is the first thing to be clarified. So we had minor side effect. In one case, well, in order to obtain the best um, uh, electrical stimulation, the best contact, electrical contact between the skin and the probe, okay, leading the electrical stimulus, you have to clean, to remove the lipid film, which is important for the skin, okay? And we ask the patient to do that by using a gauze with a alcohol solution. But that patient took us too much strong, and he worked a lot making the making a bruise on the part which underwent in addition this 14-day stimulation. So he had a local redness together with a really a small bruise, but that was not so important. Yeah.
I know of one patient who I actually happen to be friends with her, and her doctor sort of case report on her. She was using the NEMOS device from this study, sort of on her own and not very supervised by her doctors because she got it
Okay.
from a friend in Europe and mailed it to the US. And she had some hearing loss that occurred after the stimulation, and it did not fully return after the journal article says it fully returned, but she says it didn't. So I would be cautious about not using it excessively. I think there are a lot of vagus nerve stimulation devices that are being sold to our patient community by various online retailers. And, some of them are credible and they're trying to do good research and working with credible scientists to really study it in autonomic disorders. But a lot of them are just out to make a buck and sort of make these overhyped claims. Some of them, they literally don't even stimulate a part of the body that has vagal fibers. It's
Yeah.
crazy. And so just be really careful. As a patient, of course, we always want new technologies. We want to try new things. We're desperate to get better, but just be really careful what you buy or who you try it from, because I do think there are devices out there that you could easily overdo it. And we don't even know. I remember talking to Dr. Dietrich from Vanderbilt, who was sort of
Yeah.
like, I kind of think of him as like the electrical engineer of the autonomic nervous system over at Vanderbilt. And, you know, um, what is the right current? What is the right amplitude? What is the right duration? And I think the real answer is we don't know, right? We've studied a couple of versions of protocols.
Okay, let me give you a clue. We define the frequency of the stimulation, but the intensity, the amplitude of the stimulus was set accordingly to every single patient susceptibility feeling. So we tested a priori the intensity going up, increasing and increasing. When the patient said, "Well, oh, it hurts me," so we stopped and we went a little bit down. So the patient had to feel the stimulation at the beginning because there is an adaptation. So
Mhm.
after 10 seconds, you don't feel anything anymore. Okay. And anyway, even for those first 10 seconds, in every single patient, we got its specific or her specific, his specific or her specific intensity.
Something else while we have our guests listening in. So Dysautonomia International has funded 3 different vagus nerve stimulation studies in POTS so far. This one that Dr. Furlan just presented on using the NEMOS device, which is approved in Europe for seizure disorders, that sort of black square rectangular device. We funded a study using the Parasim device at University of Oklahoma, and I shared the link to that study in the chat. It's the second link I shared. And that study also looked at POTS, but they didn't divide it up between hyperadrenergic or not. They looked at it in a different way. They looked at, does it change the symptoms and the immune function? And they found that it reduced some of the inflammation that they've documented in POTS patients. And then we funded a third study at Children's Hospital of Wisconsin. Dr. Katya Corrento, who's a pediatric GI specialist. And she used the device called IB Stim, which is FDA approved for pediatric IBS, which conveniently a lot of POTS patients have IBS, right? So it's already FDA approved for at least a subset of us. And she was looking at the Ehlers-Danlos patients and POTS patients with GI dysmotility to see if this can help their pain, their GI motility, their functionality. And she also looked at some immune marker stuff. And I literally called her about an hour ago before we started to just be like, hey, do you have an update I can share on this webinar? And so her paper is not published yet. But she said the only reason why is because we have mountains of data from this study, way more than we expected to have, and all of it's amazing. And she said it had a very high rate of efficacy for the POTS patients that she gave it to, who were pediatric, GI, EDS, all the comorbidities, right? And so she was very excited about that. And the IV stim device it's a little weird. It's a stick. It kind of has a couple of contacts, and you put like a big sticker on it, and it's like a bandage for like a week, and then you take it off. So it's not the same as like a device you could just easily take on and off.
Okay.
But we were looking at the different devices because we wanted to understand the concept more than like one particular device is the best one, right? I think what the next stage of research is okay, we have three different devices that have shown efficacy. Now I think we start digging into like, what is the best device for this? Which is there a best device? Is there a best setting, a protocol? Is it 14 days? Is it
Yeah.
2 months? Is it, I think we have a lot more research to do on this before it becomes like a standard part of clinical care. But I do want patients who are listening to know, like the researchers are working as fast as they can to get this figured out and documented in research. And we are fighting for not only our grant funding to go towards this, but for government research funding to support this. We have advocated for some of that long COVID research funding from the US government and the Canadian government to go into it. And I think there's some American Heart Association research funding going into this at Vanderbilt. So I don't know. It's frustrating to not have all the answers, but I'm really hopeful that this is going to be increasingly available to people. But we definitely need more research before your average cardiologist is going to start recommending this, right?
Yeah.
So thank you so much for your time and all the work you've done on this. I know you've stayed up late with us. What time is it there now?
Oh, it's midnight, 15
Midnight.
past midnight.
Oh, well,
15 past
you
midnight.
better get some sleep so your vagus nerve works good tomorrow morning. Uh,
Yeah. Oh, well, tomorrow I've got three POTS patients to see. Yeah,
uh,
in the morning.
tell
Yeah.
them a couple hundred of us say hello. And we have
Okay.
a support group in Italy. We have a Dysautonomia International has support groups in all US states, all Canadian provinces, and about 80 other countries around the world, including Italy.
Okay.
There's a lot of great resources on our website for anyone who's new to joining us. The last thing I'm going to leave everybody with is we actually have a year-end fundraising campaign going on right now, and there's a very generous two donors who are willing to match up to $400,000 in contributions to Dysautonomia
Okay.
International
Okay.
between now and December 31st. So if anybody out there listening wants to donate, whether it's $5 or $100 or whatever you can do, your donation will be doubled if you donate before December 31st. So I hope that we can raise a lot of money to fund more research because we need more of this and more good results and more, finding ways to help people.
Okay.
So thank you so much.
Okay. It was a pleasure. Thank you very much.